hypertension and pulmonale. When is your exam?
Wednesday.
Wednesday morning?
Yeah.
Okay. So this topic is a confusing topic. It's confusing. I think it's confusing to learn. I think it's confusing to think about clinically. And it sort of is a topic that rests in the between pulmonary disease and heart disease. And so I'm going to talk primarily about the organization of pulmonary hypertension. We're going to talk about elevated pressures in the right side in the pulmonary arteries, and we're going to talk about elevated pressure in pulmonary veins. We're going to use a machine that's called, in the Middle East we call it king.
Hope not.
And we're going to talk about the classification of those diseases. We're not going to get into too much detail about specifically what's happening in those illnesses. We're not going to talk too much about the pathophysiology. But we are going to talk about the physical exam related to pulmonary hypertension. Now that might seem a little bit confusing to you because we haven't started cardiology yet. And we're going to be concentrating today on some heart sounds, which is why I asked you to bring your stethoscope. But it'll be a nice introduction into cardiology. So what I want you to try to do as I go through this lecture is try to hold in your mind what's going on. The blood's coming back in the veins and dumping into the right atrium, right? And then it's dumping at an atrial systole, it dumps into the right ventricle. And then it gets, during ventricular systole, it gets shot up into the lungs. The lung circulation, as you recall, is pulmonary artery, a whole system of capillaries, and then the pulmonary veins bring it back to the left atrium, into the left ventricle, then out to the rest of the body. So I want you to begin to think about that and try to hold in your mind what that picture looks like as we go through talking about what's going on, okay? If you have questions about anything I'm saying, raise your hand. Clinical medicine is much more difficult than the basic sciences. Clinical medicine is much more difficult than, let's say, human anatomy, because the words we use are ambiguous in clinical medicine. They're not specific, like the name of an enzyme. And so when I use a term that you don't understand, raise your hand so that I can explain what I'm saying, because it can be really confusing. Do we want to update that job? All right, so what's the definition? Pulmonary hypertension. It's the elevated pressures in the pulmonary vascular system. That means the pressures can be elevated on the arterial side, coming out of the right ventricle, or they can be elevated on the venous side, coming back into the left atrium. Definition of cor pulmonale. You'll hear that term pronounced cor pulmonale, cor pulmonale. I say cor pulmonale, I don't know why, probably because that's how I heard it the first time. Elevated pressures in the pulmonary vascular system leading to enlargement of the right side of the heart, usually the right ventricle. So when you hear the term cor pulmonale, it means that the right ventricle is dilated, okay? And it's always due, well, it's usually due to pulmonary hypertension. Okay, let's talk about pressures in the heart. I'm going to make it easy. Nickel, dime, quarter, $1.25. Okay? Nickel, dime, quarter, $1.25. Pressure in the right atrium is 5. Pressure in the left atrium is 10. Pressure in the right ventricle is 25. Pressure in the left ventricle is 125. Now, of course, that's wrong, right? That's baloney. Because the pressure's changing all over the place. The pressure's one thing before the atrium contracts, it's something else when the atrium contracts. I mean, but let's not get too hung up about it. A nickel, dime, quarter, $1.25 will get you through life. It'll get you through the clinic, and it'll get you through most of the exams. And it's easy to remember. Okay, so what's the pressure in the normal pulmonary artery? 20/10. 20 is the pressure in the pulmonary artery at the end of ventricular systole, as the right ventricle is contracting to put the blood into the right ventricle. And after the pulmonic valve has closed, the pressure in the pulmonary artery is 10. It's just like over on the other side of the heart, 20/10. Now, that means that the resting mean pulmonary artery pressure is around 15. And clinically, when you're seeing patients in the medical ICU, they'll be talking about a pressure called the mean arterial wedge pressure. And it will be, an abnormal one will be above 15. But the mean arterial pressure in the pulmonary artery is around 15. That's normal. So pulmonary hypertension is defined as a mean pulmonary artery pressure of 25 or greater. Right? Now, so you might ask yourself a question. If you're saying normal is 15, why do you wait till 25 to call it pulmonary artery hypertension? And the reason is that in this body of ours, there's a wide range of variability. There's a lot of variability. So we don't get all worked up over a pressure of 18 or even 20. Okay? So remember that. Pulmonary artery hypertension is defined as a mean pulmonary artery pressure of 25 or greater. Now, we're going to run through a series of 5 slides that are a diagnostic classification. This is just a list of things that cause pulmonary hypertension. And we'll talk a little bit about some of the pathophysiology, and some of it we'll just kind of ignore. Pulmonary arterial hypertension can be, well, it's related, it's called primary or secondary. Now, primary pulmonary hypertension can either be sporadic or familial. In other words, there are some babies born with pulmonary hypertension. It's a really bad thing. And there are some genetic causes of that, which I didn't put on this slide because you don't even know it. But you just need to know that sometimes there's a genetic abnormality, a mutation in the genes that leads to the baby being born with elevated pressures in the pulmonary artery. These are familial. Here are the pathophysiologies in the small pulmonary arteries and arterioles, causing constriction of the arterioles or arteries, and therefore raising the pressure inside the vessel. Pulmonary artery hypertension is also related to collagen vascular diseases. Now, when I say collagen vascular diseases, it can be related to any of them. Lupus, rheumatoid arthritis, all of them. So collagen vascular disease. There are congenital systemic to pulmonary shunts. There are babies born with congenital heart disease. And if in that congenital heart disease there's a shunt between the circulation on the left and the circulation on the right side of the heart, the pressure will be too elevated on the right because you're shooting blood in there at 140 millimeters of mercury. Does that make sense? Portal hypertension. Remember remember the portal vein from Gross anatomy? Portal vein is coming out of the hepatobiliary tree. Portal hypertension occurs in liver disease, like chronic hepatitis or alcoholic liver disease. When the pressures are elevated in the pulmonary venous system, it causes elevation of pressure in the right side of the heart. And that pressure on the right side of the heart can be translated hydrostatically, hydraulically, all the way into the pulmonary artery. Does that make sense to you? HIV infection can cause pulmonary hypertension, and no one has a clue why that is. The pathophysiology has not been worked out. And then there are drugs and toxins. The two that you will likely run into in ERs in Oklahoma are methamphetamine and cocaine. They can cause, and if you snort or inject cocaine long enough, you can get sustained constriction of pulmonary arterioles and sustained pulmonary hypertension. Anytime a patient or a person takes cocaine or methamphetamine, the pressures go up in the arterial system, whether it be the pulmonary system or the systemic system. But chronic use causes a pathophysiologic change in the vasculature of the lungs, and you can get sustained pulmonary hypertension. Bleomycin is a drug caused to treat cancer, and for whatever reason, I never have bothered myself with trying to figure out why it does it, but if you use bleomycin to a certain dose, the patient can get a side effect called pulmonary artery hypertension. Part of medical education, I think, one of the most important parts of a medical education is trying to figure out what you can forget, and why bleomycin causes pulmonary artery hypertension is on that list. That list is getting longer and longer as the years go by, too. Okay, so that was pulmonary artery hypertension. Now we're going to talk about pulmonary venous hypertension. We're talking about the pressures in the vessels coming back to the left atrium. Okay, so this is caused by diseases of the left heart, and as we go through cardiology, what you're going to sort of begin to appreciate is that these diseases on the left side of the heart seem to be more dramatic. They seem to be more common. They seem to be more important. And I suppose all those things are true. And so you'll spend more time talking about left-sided heart diseases than you will right-sided heart diseases. Left-sided ventricular heart disease, that's heart attacks. That's left ventricular cardiac failure. That's left heart valvular disease. And then pulmonary veno-occlusive disease falls in this category for a variety of reasons. But what we mean by pulmonary veno-occlusive disease is that the veins coming back to the left atrium, for whatever reason, are clotted. There are clots in the pulmonary veins. That's not particularly common. The clots generally occur in the right side of the heart. Pulmonary emboli and clots in the right side of the heart where the flow is less aggressive, slower, lower pressures. But pulmonary veno-occlusive disease in patients who have trouble with blood clotting can occur. If that's chronic, then you have this pulmonary veno-occlusive disease. It's a really uncommon thing. Left-sided ventricular disease is really common, and left-sided valvular heart disease is real common. Now, this slide is basically the same as one you're getting ready to see that says Pathophysiologic Classification passing. So you all have access to these slides to study with, right? So you'll see on another one that's coming up, same information. Okay, pulmonary hypertension associated with disorders of the respiratory system. So one of the reasons this stuff is sort of difficult to sort out in one's mind is that this business of the pulmonary circulation, where in the lungs, the pulmonary arteries lead into capillaries, and the blood leaves out of the capillaries into the pulmonary veins, is intermixed with the alveoli. Right? The alveoli of the lungs, the interstitium of the lungs, this is all mixed up. It's like the gravy and the mashed potatoes on the plate, and the corn that Mother put on there, and it gets all mixed up. My sister said, "Don't mix them up, don't mix them up." They're all mixed up in the lungs, and so it's hard to kind of wrap your head around. As you think about COPD, you just covered that, right? As you think about COPD, maybe from smoking, what you've got is a disease of the bronchioles, whereby you can't exhale the air correctly. But if you think about the pathophysiology and the pathology of those lungs when you have COPD, it has to affect the circulation. Does that make sense? You got those blebs. You've got fibrosis of the interstitium, and you've got all these little tiny vessels running through it. So there's no way that a disease like COPD, which affects the lungs in general, doesn't affect the circulation of the lungs. Exactly how it does that is in that pile of things that I'm not going to worry about. I just know it does it. And interstitial lung disease is the same thing. Interstitial lung disease, which is different than obstructive pulmonary disease. Interstitial lung disease, which is less common than COPD, but nonetheless, it does it the same way. When you get fibrosis, interstitial lung disease is primarily fibrotic lung disease, right? And when you get fibrotic lung disease, it affects all these small arteries and small veins that go through the lungs. Sleep disordered breathing. So this is sleep apnea. Did you talk about sleep apnea? Really common, and it's unclear to me why sleep apnea causes pulmonary hypertension, but it does, it can. Now, pulmonary hypertension will not be the reason the patient presents. The patient presents with sleep disordered breathing because their spouse can't sleep because they're snoring so loud. Or they're having apnea in the middle of the night and their spouse thinks they're dying. Or they're falling asleep at work, or they're falling asleep in PA class when some dummy's talking about pulmonary artery hypertension. Alveolar hypoventilation disorders. This is alveolar hypoventilation. Did you use that term? Did you learn that term at all? I think what they primarily mean by alveolar hypoventilation disorders is central sleep disordered breathing. Central meaning brain. So most of the sleep disordered breathing most of it is mechanical in the upper airway, where when you take a deep breath, or when you inhale, the tissues collapse and you can't get air in. But there's also a very rare central lesion of the brain, which we don't understand very well, that causes people to quit breathing during sleep. I don't know why they call it alveolar hypoventilation. That's, I think, what they mean by that. Number 4, pulmonary hypertension owing to chronic thrombotic and/or embolic disease. So this is disease on the right side of the heart, where the blood's coming out of the right ventricle into the lungs. If you have a blood clot in your leg, say you had surgery yesterday, and the surgeon forgot to order heparin, and you're laying there, can't get up, hurting, and you get a clot in your thigh, in the big vein in your thigh. And then you get up, go to the bathroom on the 3rd day, and you constrict those muscles and so forth. That clot breaks loose and goes to your lung, up the venous pathway and into your lung. You have a pulmonary embolism. You talk about pulmonary emboli. And if you have pulmonary emboli over and over and over, you can get chronic thromboembolic obstruction of the pulmonary arteries. Sickle cell disease can present this way as well, because someone who is chronically sickling has difficulty getting those red blood cells. Sickled red blood cells don't squeeze down very well to get through the precapillary arterioles, and so you can get chronic thrombosis on the right side of the pulmonary circulation. Does that all make sense? Pulmonary hypertension owing to disorders affecting pulmonary vasculature. Sarcoidosis is just another lung disease. It's fibrotic. It's of unknown origin. It's of unknown cause. It causes fibrosis of the lungs, which interferes with circulation for the same reason that COPD does, because all those little arteries and all that lung tissue is intermixed and mixed up. Scleroderma is a disease. It's one of those collagen vascular diseases in which the pathophysiology is literally in the precapillary arteriole. Patients with scleroderma present with facial manifestations because the skin on their face is affected by the arterial disease in those small, they have it all over their body, but it's most obvious to us because we're naturally born to be able to recognize facial features. You know, we forget names, but we never forget a face. And when the face doesn't look quite right, one has to begin to ask themselves, what's wrong with that face? And scleroderma causes some facial abnormalities that are pretty remarkable. They also have problems with their hands. Because we use our hands so much, the precapillary arterioles in scleroderma get constricted, and the blood flow is constricted into the capillaries all over the body, but they get symptoms in their hands because we use them so much. I had a medical student who had scleroderma, and she couldn't write long enough, she couldn't hold a pencil long enough to write her name. She'd get about half her name, and then she'd drop the pencil. The pain was so severe in her hand. So scleroderma causes pulmonary hypertension. It's causing precapillary hypertension all over the body, really. Okay, so pathophysiologic classification. Precapillary is what I've just been talking about. Precapillary pulmonary hypertension is like scleroderma. That's the arterial on the front side of the capillary. And then postcapillary hypertension is passive, meaning that the reason that the pressure in the postcapillary pulmonary vein is high is because there's disease on the left side of the heart, and this backup of pressure, I call it back pressure. The pressure in the postcapillary venule is caused by this backup, and the back pressure is caused by left-sided heart disease, heart failure, left heart valve disease, myocardial infarction. So this passive part here is the same as that other slide, right? That I showed you before. Those are not different things, they're just written down in different classifications. Any questions about this classification for disease? I would probably try to think of what are these five big classifications of illnesses, and think of examples in each one of them, and then you pretty much got it. Now, how do patients present? This is one of the things that's difficult about pulmonary hypertension and pulmonale, is that when it's mild, they don't present with anything. When the pressures are mildly elevated, say 25, 26, mean pulmonary arterial pressure, they don't present with any symptoms. They might come in saying they have a little fatigue, or they might say they have a little bit of chest discomfort, but my goodness, that's common, right? These symptoms are so common that you wouldn't just start working them up for pulmonary hypertension. What you would do when the patient presents with dyspnea, which is the most common symptom associated with pulmonary hypertension, what you would do when someone presents with dyspnea and you've already ruled out all the common causes, then you might start looking for something rare like pulmonary hypertension. So here's the way this looks. If that's dyspnea, this is pulmonary artery hypertension, right? Dyspnea is the most common symptom in pulmonary artery hypertension, but it's not even close to the most common cause of dyspnea. I was dyspneic yesterday morning at the top of Vale Pass, 10 inches of powder on the mountain. It was 11,500 feet. The oxygen concentration at altitude was low. And I was trying to ski around some bumps on blue. It was just funny. Isn't that amazing? Isn't travel just remarkable? It was April. They had 15 inches of snow in Vale last week. Did you see that? That was awesome. I was dyspneic. I didn't have pulmonary artery hypertension. Okay. In early or mild pulmonary hypertension, there are no physical findings. Physical exam would be normal. So let's talk about what the physical findings are. Now we're going to talk primarily about the cardiac exam. Okay? And the reason I ask you to bring your stethoscopes is that I want you to listen to your own hearts and to think about cardiac exam. So there are two heart sounds. All right. I was talking to Mark Britton the other day about learning cardiology, learning heart and lungs. I was saying, you know, the reason I think they're really hard. I think learning to do and to do the heart and lung exam and to know what you're hearing and seeing is really hard. Okay? I don't think it's easy. I think everybody thinks it's easy, especially the lung exam. You just put your stethoscope on there and tell them to take a deep breath. What the hell is hard about that? But hearing and comprehending, knowing an abnormal sound when they're taking a deep breath. It's really hard. Okay. One of the reasons it's hard, in my opinion, is that it's very difficult to hold in one's mind a picture of what's going on. It's easy on the musculoskeletal exam, right? I got those meniscuses and those tendons and stuff. I could have done one yesterday morning. I could have ripped that ACL so quickly. 70-year-old ACLs are brittle, so I take it easy. But you can't see it in the heart and lungs. So what we're going to try to do is draw some pictures and try to figure out what kind of a picture do I have in my mind as I'm listening to these things. The first picture I want to draw is S1 and S2. Okay? Now S1 is caused by the closure of the valves between the atria and the ventricle. That's also hard to get your head. It's not caused by opening, it's caused by closure. So that S1 is the AV valve closing, getting ready for the ventricles to contract, right? And as the ventricles contract, the aortic and pulmonary valves open. They open passively because the pressures increase, right? The ventricles contract, pressures go up, and those valves open so that the blood can go into the lungs and into the rest of the body. And then you hear a second heart sound, and that's closure of A2P2. S2 is the second heart sound. A2P2 are the two components of the second heart sound. One's aortic and one's pulmonic, A2P2. Okay? What causes the sound? Turbulence. Yeah, it is. Yeah. It is turbulence. What does that mean?
The air constricts as the space constricts as the valves are closing, right? So it's like as the blood shooting through those quickly.
It's pretty good. I don't know. I'm not quite smart enough to figure this out. You know who figured this out for the very first time that we know of? Leonardo Davinci. Leonardo Davinci had some papers. He never published anything. He had some papers that they found at his death. He had 782 observations, different observations, of the flow of water. 782 different observations of the flow of water. He studied water in rivers, and so he studied, what he was studying is turbulence, and just made unbelievable observations about water. He also, dissected. He dissected before it was okay with the Catholic Church to do so, but he also did it after the Catholic Church decided it was okay to do so at the University of Padua. And at Padua, he would go into the medical school anatomy class, and the professor would read the anatomy, the students would be dissecting, and he would be drawing his famous drawings. He had the most remarkable, maybe to this day, some of the most remarkable drawings of anatomy. And so he knew what the aortic valve looked like, and he knew that the ventricle was a pump of some sort. He did not know that the blood circulated and came back to the right side of the heart. Everyone thought at that time that the blood just sort of seeped through, the ventricular septum. But nonetheless, he took all that knowledge he had from observing water and said to himself, what happens, why do these valves close? If you're in there dissecting them, they just do this. They're flaps, kind of. But that aortic valve, which has three cusps, and the pulmonic valve, which has 3 cusps, opens and closes every second for 70 or 80 years. And doesn't usually wear out. In most people, for 70 years. After 70 years, it kind of starts wearing out a little bit. Mine wore out earlier. Mine wore out about age 40 because mine only had 2 cusps instead of 3. I was born with a bicuspid aortic valve. And sometime during the cardiac thing, I'll come in and let you listen to my aortic stenosis. I haven't had mine fixed because I can still exercise, but it'll probably have to be fixed if I don't get hit by a bus first. But I have a really nice, or better yet, shot by a jealous husband climbing out of the bathroom. Or bus, or but most of these bicuspid valves wear out, and they wear out a lot earlier. And you start hearing this aortic stenosis, and so I'll have you all listen to this aortic stenosis sometime next month. Okay, so there's an increased intensity to P2. So here we are. This is systole. And this is diastole. Now, why does that picture make sense to me? It makes sense to me because systole is a shorter period of time than diastole. So you put your stethoscope on the chest and you're trying to figure out which one's S1 and which one's S2. Now, here's the deal. And you all know this. You probably you may not have just thought about it very much. But the heart doesn't sound like this. Bump, 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 bump. It sounds like this. Bump, 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 bump. And it does so because diastole is longer than systole. Bump, 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 bump. So, grab your stethoscopes, put them in your ears, put it at the base of your heart. And the base is up here. The base is up here. So put it up here and listen, and just put it on there and listen for S1 and S2 and try to figure out which one's S1 and which one's S2. Okay, now, I'm going to give you Veneta's first rule on examination of the heart and lungs. You put the stethoscope on the skin. I catch you listening through your shirt, and you get a triple F zero. So, listen to the base of the heart. S1 and S2. Okay? Everyone figure out which one's S1, which one's S2? Okay, now the next thing to do is listen again and see if which one is loudest. Is S2 louder? Why is that?
More pressure.
What?
More pressure.
More pressure? Well, there's more pressure than what?
On the aorta.
Yeah, A2 has a lot of pressure coming out to it. But on the other hand, the pressure coming out across the aortic valve is about the same as the pressure closing these valves. The pressure closing these valves is the pressure inside the ventricle. It's about the same as the pressure going out the aorta. Damn good guess, but not quite right. This is the other thing that's hard in medicine. And this is the other thing that's uncommon in medicine. What most medical students and what most PA students do is spend the first year or two of their education memorizing crap. Mostly stuff that doesn't matter. Think of all that anatomy stuff. Wouldn't be able to memorize it. Don't tell me. Okay, so why is S2 louder than?
Because you have something at the base of the heart, so those valves are closer.
Yeah, that's where they are. That's where they are. The aortic valve, if you put your right hand or your thumb out like this, right in the middle of your chest, your right thumb will be the aortic root. Okay? So your aortic valve is sitting right there. That's where your aortic valve is, in the right second interspace. And your aorta comes up and dives down behind the heart, right? So the aortic valve should be loudest right there. And the pulmonic valve should be loudest right there. And they're on the superior part of the heart. We call that the base. That's a confusing, usually we think of the base as being at the bottom, but the base of the heart is at the top. So if you were to move your stethoscope down by the apex, then S1 might be a little louder than S2, okay? But we're going to concentrate on S2. The first thing you got to figure out is what's S1 and what's S2. You just did that. I don't mean, yeah, you figured out what's S2. It's loudest at the top, and it's at the end of systole. Now, we talk about A2P2, and we don't ever talk about tricuspid 1 and mitral 1. We just think of the S1 as one sound, but we think of S2 as two sounds. We think of it as A2P2. And we think of it as A2P2 because in the normal human being, the aortic valve will close before the pulmonic valve. What Leonardo da Vinci figured out was that the ventricles contract, those three leaflets fly open, and the blood gets shot through the aortic valve, and when it does so, it becomes turbulent. And we can now see it in vivo with technical visions. But what happens is he figured out that this blood is hitting the wall of the aorta and it's hitting the valves, and it sets up a circulation that and the fact that at the end of systole, the blood's now trying to get back in the left ventricle. And it pushes the valves closed. So the pressure of the blood trying to get back in the left ventricle closes. But also, before that happens, this turbulence causes it to close. Okay? And that pressure in the left side of the heart is greater than the pressure in the right side of the heart. So the aortic valve closes a little bit below, a little bit faster, a little bit earlier than the pulmonic valve. Okay. Now, I'm going to do one more thing with your stethoscope. This is going to be a lot harder. But you're young, your physiology is young, your anatomy is young, so get your stethoscope back, and I want you to listen for A2, or P2, S2. Listen for S2. And then listen to it for a while, and then take a deep breath and try to figure out what happens to the second heart sound when you take a deep breath. You might have to do it 4 or 5 times. hear any difference with a deep inspiration? What do you hear?
Or sorry,
S2 what? It's
quiet.
quieter.
Or slows down.
What else?
Mine might sound like it skipped a beat. Sped up.
Skip the beat and sped up. It might have. But that would have been just a happenstance. Listen again, but put your stethoscope in the left second interface instead of the right. And listen again and try to figure out if it's different between expiration and inspiration. Left.
We did left first.
Oh,
We left. We
do it again.
We're rebel.
You're rebels. Yeah. Does anyone hear it splitting? Does anyone hear that second heart sound splitting into two sounds in inspiration? Someone does? No one does? Some do. Maybe. It's very, very subtle. Okay? Now, what's going to happen this year and next year and the next 5 years is that you're going to put your stethoscope on about 100,000 patients' chests, and you might learn something or you might not. Most people don't learn anything when they put their stethoscope on someone's chest because they're not thinking about what they're doing. They're not being mindful about what they're doing. Okay? Let's talk about how many actually heard the second heart sound split during inspiration? One?
If it sounded different, yes.
Two? It was a little different? A little smudgier maybe? It might have just been smudgier because S2 widens out. Here's what happens. This is the aortic valve, closing just before the pulmonary valve. But in the normal situation, it's so close that it sounds like one sound. It's S2. Okay? And for sure in expiration, it's the same. In inspiration, P2 widens out from it so that in certain circumstances, in most circumstances, a deep breath causes that heart sound to widen out, and you can hear it split. That's called physiologic splitting. Why? Here's a good question. Why, during inspiration, would the second heart sound split? Why would the pulmonic valve close later than the aortic valve in inspiration?
Aren't you like expanding your lungs?
I'm sorry?
When you breathe in, you're expanding your lungs, so you're expanding those capillary fields to what their maximum would be, so more blood can get in there?
Yes, that's true. That is exactly true, but it's not, yeah, but it's not because the lungs are expanding. But that is true. It's for a different reason, but that's exactly right. Why did the lungs expand? Here's the reason. It is for that reason. Why did the lungs expand? What?
To take more.
Why is it getting air in it?
Difference in pressure.
Because what?
Pressure.
Pressure. What's the pressure doing?
It's going from a higher to a higher.
Yeah, pressure's dropping inside the chest. Right? All you got to do to inspire is what?
Lower it.
You do change the pressure. How do you change the pressure inside your lungs to inspire? What?
Expand the volume.
You make what?
Increase the volume.
You, you make the volume bigger by doing what?
Lower the
By
diaphragm.
contracting the diaphragm. Yeah. Contract the diaphragm, and then the air just flows in. And then you got to work to get the air out, right? You got to do all kinds of stuff to get the air out. But getting it in is real easy. You just contract the diaphragm. Okay, so you contract the diaphragm goes down, chest gets bigger, the pressure drops, and the air just flows in. Okay? What does dropping the pressure inside the chest do to the right-sided pulmonary venous or pulmonary artery flow? So the pressure is lower, the pressure inside the chest is lower. All this blood coming from the veins flowing into the right side of the heart and into the right ventricle and then is flowing faster and it's flowing longer during an inspiration. Pressure drops, more blood flows through. So if you increase the volume of blood coming across the pulmonary valve will close a little later. That's not going on in the left side of the heart. The pressures are so high in the left side of the heart that pressure difference inside the chest doesn't matter to the aortic valve, but it does matter to the pulmonary valve. So that's what physiologic splitting of the second heart sound is. I'm going to add one more hint. I'm going to add one more hint before I get on with this and close this lecture. One of the ways to learn a lot about the examination, auscultation of the heart is to do it every time in a systematic way. You'll get some lectures on physical diagnosis of the heart, and they will probably go through the systematic way to do it. Okay? Here's what I would recommend. Put your stethoscope on the chest somewhere, probably just to the left mid-chest, with the diaphragm, that's the big part. And you do it just like you do when you go to the symphony. You go to the symphony all the time, right?
Of all the time and money I have, yep.
All that extra time you have. You have nothing to do at night. So you go to the symphony, and there are a variety of things you can do. You can sit down and listen to whatever the song is they're playing and just enjoy the melody. Just enjoy the song, right? Which is what most of us do. We sit there, we listen to it, we say, I like that or I didn't like that, that was very enjoyable, I didn't like that, and you leave. Now, you might also, if you were a musician and your ear was tuned to know what you're hearing, which mine is not, you might say, on this next song, I'm going to try real hard to figure out what the first chair violin is doing. And there's all this sound coming in But the trained musician can use their brain to find the first chair violin. Maybe by watching them, maybe by listening carefully, or I'm going to listen to the percussion, or I'm going to listen to the trombone. Right? So you have to use that technique when you're listening to the heart, or you'll miss most of the findings. Okay? So you put your stethoscope left sternal border, and you just listen to the symphony. Boom, 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 boom. 80–90% of all patients you put your stethoscope on, that's all you're going to hear. It's a nice symphony. Boom, 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 boom. Now, you're not through. Just because you didn't happen to hear a murmur, or didn't happen to hear a galloper, you're not through yet. You just listened to the symphony. Now I'm going to listen to something specifically. Listen here and listen here to see if the second heart sound is right. Does it split with inspiration? Is it louder up there than it is where I first listened? It should be. The second heart sound should be louder up there than when I keep it on there long enough to see them through some inspirations. When they inspire, does the second heart sound physiologically split? It's nice. It's a nice thing. Now I might listen to all the places in the heart where you're supposed to listen for mitral, tricuspid, aortic, pulmonale with my diaphragm to see if I can hear any murmurs. Okay? Then I turn it over and use that little tiny thing. Let me see your, oh, I've got a little pocket. This little thing here, the bell. Now the bell, this is also something we don't see. The bell is meant to hear very low-pitched sounds. The closure of the valves and the murmurs are almost all very high-pitched, high-frequency sounds. See, this is a little bit like music, because the murmurs are high-frequency sounds. So is S1 and S2. And that's heard with the diaphragm pressed carefully against the chest wall. If you want to hear something really low-pitched, really low frequency, you turn this over and you lay it on the chest so that it's barely laying there. No pressure on it like this. Maybe just seal it, but don't put any pressure on it. If you put pressure on the bell, it starts acting just like a diaphragm. Okay, so this little bell thing is for low frequency sounds. What are the low frequency sounds? S3 and S4. They're not normal sounds. S3 and S4 are abnormal sounds, but they're caused by a different thing. And their cause is such that it's a very, very low frequency sound. Have you heard the term gallops? These are called gallops. This isn't going to be on your exam because your exam's about the lungs. But I don't get to talk to you very much in cardiology except for teaching you EKG, so I'm going to go ahead and tell you because it makes me happy. In the Middle Ages, no, sure it wasn't in the Middle Ages. When was the stethoscope invented? 1800s? Who invented it? He wasn't dead when he invented it? No, he was alive. Frenchman. I'm blocking on his name right now. But he didn't know what he was hearing, and he heard before he invented the stethoscope, how was the heart oscillating? Put your ear around on the chest wall. This was very, very difficult with female patients and male physicians. All the physicians were male, half the patients were females, and so he invented the stethoscope so he could get his head away from, his ears away from the chest wall. So he hears these sounds, and in some patients he's hearing these little other sounds, S3 and S4. So let's say he heard S3 first. I'm sure that's what he heard first because it's more common and it's louder. He didn't know what to call it. And he had no reference. So what do you suppose he chose in the 1800s? What would he choose to name it?
After a horse,
What?
like a horse gallop?
Well, that came a little later, but it does sound like a gallop. Da-da, 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 da-da. Sounds a little bit like a gallop. Da-da, da. What was known back then by educated physicians was that it sounds like the foot meter of a poem. And an S3 gallop is a dactyl. Da-da-da, da-da-da, da-da-da. Tennessee. It's a dactyl. If you read James Joyce's most famous book,
Ulysses?
Ulysses, in the first chapter of that book, there's a character. His name is Malachi Mulligan. And he walks in the room and he announces to his friends, "My name is Malachi Mulligan. I'm a medical student and I'm a double dactyl." That's what he says. I'm a double dactyl. Malachi. Mulligan. He's an S3 gallop. Malachi. Mulligan. He's a double dactyl. Malachi Mulligan. James Joyce was just showing off. But it's a dactylic, so it was called a dactylic sound until someone said, no one's going to remember that or know what a dactyl is, and so they started talking about gallops. And so now we call it an S3 gallop, and because it sounds a little bit like a horse coming down the path. And then if the sound is over here, right before S1, we call it the S4. It's in late diastole, right before systole. Kentucky. And that's an anapest. That's an anapestic sound. And if you hear all of them, you can sometimes hear S1, S2, S3, S4. Now you're hearing a summation. It's a summation gallop, they call it. It's all of them. And it literally sounds like that's pretty good. Huh? I can't play in the symphony except the drums. Okay. So you put your stethoscope on with the diaphragm and you're listening to the symphony. And most of the time, it's just going to sound like all I hear is S1, S2. But your brain might go, something else is going on. So then you have to listen very, very carefully. You listen up to S1, you listen up to the bass to see if S2 is physiologically split. Then you turn that thing over and you're listening around a variety of places over the anterior chord to see if you can hear an S3 or an S4. S3s and S4s are very low frequency sounds because here's what causes them. They're in diastole, they're not in systole, right? They're in diastole, So S3 is In early diastole, what happens is the ventricles have just finished contracting, right? And in early diastole, the tricuspid and mitral valves open. And blood that's been accumulated up in the atrium just falls. It just falls passively into the ventricles. That's what happens in early systole. Blood falls passively into the ventricles. Then there's a time when it's still falling, and then right here it contracts. The atria contract late in diastole to complete the filling of the left ventricle. Okay? Now when it opens and the blood falls, to understand what the S3 is, you got to think, how many of you are soccer players? How many have seen a soccer player? So there's a thing in soccer called a pass, right? You kick the ball and you receive the ball. But you don't use your hands, you got to use your feet. How do you receive the soccer ball without it bouncing off? You receive it and keep it. How do you do that? You give. The ball's coming, and you let the ball hit your foot, but your foot's giving. And it'll stop right there, if you do it right. If you just put your foot as a wall and bounce back to the guy who sent it to you. Right? That's what the ventricle does. When the ventricle is young, and healthy, and pliable, and the aortic ventricle valves open, the blood just falls in there. The ventricles go and receive it. If, on the other hand, the ventricles are 60, 70, 80 years old, they've been subjected to systemic hypertension, they've been subjected to God knows what all, smoking cigarettes, the walls are stiffer. And so when the blood falls, the blood's hitting a non-compliant wall, like your foot was stationary and the ball bounced off. There's a louder sound when it bounces off than when you allow it to just hit your foot. So an S3 gallop is blood passively hitting the wall of the left ventricle during early diastole, and the wall is not very compliant. We hear it in congestive heart failure. The S4 is the same thing, except it's in the late diastole where the ventricle has now contracted. It's blood hitting the ventricular wall late during that last phase when the atria contract. But you won't hear it. You won't hear it unless you say to yourself, I'm going to listen for the first chair violin. I'm going to turn this thing over and I'm going to listen carefully for an S3. And the only way you'll hear it is if you use this. You won't hear this. If you use this lightly on the chest and you concentrate to hear it right after S2. It's so soft, you'll miss it. So you literally have to be mindful. I think it's true of the whole physical exam. It's difficult to learn the whole physical exam. You got to learn to do it mechanically, right? There's a mechanical thing you got to do. Using the hammer, using the otoscope. The stethoscope's no different. And you've got to be mindful about what you're listening to while you're doing it. Then after you've listened for S3 and S4, you got to listen, you got to pay attention. I'm going to now pay attention to nothing but this space between S1 and S2 to see if there are any murmurs. And then I've got to listen to this space to see if there are any diastolic murmurs. All right. Now, this says that there's an increased intensity of P2. Why would there be an increased intensity of P2 in pulmonary hypertension? There's an increased pressure behind the valve as it's closing. The pressure in the pulmonic valve is increased, so as that blood is trying to get back in the right ventricle, the pressure is too high, so the intensity of that sound, the flow of blood is more intense. The velocity, there's more kinetic energy in the root of the pulmonic valve coming back against the pulmonic valve, and so the sound is more intense. Just now, you had a hard time hearing P2. So trying to figure out if P2 is increased in intensity might be a little stretch for the first semester PhD. But if you aren't mindful, and if you aren't thinking about what's causing it, you'll never hear it, okay? Now, murmurs of pulmonary and tricuspid insufficiency, that's true, that you might hear pulmonic insufficiency. I don't know if I've ever heard that. I don't think I have. No, I know for a fact, I've never put a stethoscope on a patient's chest and said, oh my God, they have pulmonary insufficiency. I've never done that. It's really, 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 really uncommon, and I probably wouldn't hear it if they had it. But tricuspid insufficiency, which would be blood coming out of the right ventricle back into the right atrium, is really common. It's really common. It's probably the most common systolic murmur, and I've heard that 1,000 times. You'll learn a lot more about how to diagnose tricuspid insufficiency in some of the lectures next month, this month. Tricuspid insufficiency may be heard in this situation because the pulmonary hypertension is caused by the left side of the heart. It's caused by dilatation of the right ventricle and disease, and if the disease causing dilatation of the right ventricle is also causing pulmonary hypertension, then they would be associated, but it's not a diagnostic finding. And then you might find increased jugular venous distension as the patient's laying on their back at 30 degrees. You see the blood backed up in their internal jugular vein, and that would be caused by something causing pulmonary hypertension that was one of those passive causes, like portal vein hypertension, something causing the backup of pressure on the right side of the venous system. So there are 3 questions down here below stop. There are 3 questions that you should get with a partner sometime outside of class when you're studying with a partner, and make each other answer these questions satisfactorily. What causes the sound we call S2? Where on the chest should it be loudest? And what causes splitting of S2? If you can answer those 3 questions reasonably, rationally, and your explanation makes sense to your partner, you probably know what we've been talking about for an hour and 20 minutes. Okay? The easiest slide is treatment. Oh, diagnosis. This is slide 2. History and physical exams, mostly not useful, because the symptoms they might have with pulmonary hypertension are so much more common than everything else that they're not very helpful. Chest X-ray, not very helpful. EKG, not very helpful. Echocardiogram, more helpful, because you can get an estimate of the pressure in the pulmonary artery with an echocardiogram. And a right heart cath is the diagnostic test. So if you've ruled everything else out and you're trying to figure out, does this patient have pulmonary hypertension, you got to get a cardiologist to put a catheter in the right side of the heart and measure the pressure across the pulmonary valve, and then you've got a diagnosis. Okay? Therefore, if you suspect it for some reason, it's a referral case. You got to get someone else to deal with it. And treatment is completely out of our hands. as the generalist, unless you're working for a cardiologist. If you're working for a cardiologist, you'll learn what they treat pulmonary hypertension. This is an interesting. So there's not any questions on your test about the treatment because it's not in your wheelhouse, what they say. Is that right? Wheelhouse? It's not in my wheelhouse. Yeah, my kids say that. They never been on a book in their life. Okay, so one more interesting story. You'll probably get some lectures in this pulmonary or cardiac thing coming up about drugs that relax vessels, right? There's a drug that the basic scientists figured out worked on nitric oxide receptors and therefore dilated vessels. And they decided they were looking for a drug that would dilate the arterioles in people who were born with one of these primary pulmonary hypertension. So you're born with pressures too high in your pulmonary arteries in the right side of your pulmonary circulation. And this is not a good thing. This causes bad disease early in life. So they're looking for a drug to do that, and they start using it. And they use it in adults first, adults who have pulmonary hypertension for a variety of other reasons, say scleroderma or cardiovascular disease or whatever. And the men start showing up in clinic and saying, I don't know what this is doing to my lungs, but this is causing my sex life to be really, really, really good. And so they figured out that it was doing more to the venous side, and it's sildenafil, and later Viagra. The drug that was released for pulmonary hypertension is the same molecule, sildenafil something, I don't know.
Citrate.
Citrate? It's the same drug as the drug that they use for erectile dysfunction, but is still on the market. It has a different name than which I can't remember, but it's on the market, but about a tenth the price of Viagra. For reasons that are pretty obvious. There aren't very many people with pulmonary hypertension. There are lots of people with erectile dysfunction. Okay, so treatment left up to the pulmonologist and cardiologist. Questions? I can't remember what the questions are for this exam, but they're pretty easy, I think. They're not, if they have anything to do with this examination stuff I was talking about, it'll be with the A2P2 business. You got to know the A2P2 to understand pulmonary hypertension. And you got to realize, so I didn't really go into this. We talked about the physiologic splitting of P2, just from dropping the pressure inside the lungs, right? But if you have pulmonary hypertension, you're going to have closure. You're going to have late closure of the pulmonic valve every time, right? Because the pressure is taking longer to get the blood in there, and so it's later for the pulmonic valve to close. All right? That's called fixed splitting. When you have significant pulmonary hypertension, that second heart sound is split during inspiration and expiration. It doesn't matter because now the pressures inside the pulmonary artery are so much greater than the differences between the pressures in the chest from inspiration and expiration that it overrides all that business, and now you have fixed splitting. of second heart sound. If the heart sounds are on your exam, that'll be related to A2, B2. So you gotta know that. Questions? Wednesday, you'll have your exam, and then we get together Wednesday afternoon, about 1 o'clock, I think, and we start learning how to read EKGs. And I appreciate that you'll be mostly brain dead at 1 o'clock. But nonetheless, I'm going to give you a really important lecture. That's one of the problems, trying to get all this done in 12 months. It gets piled on top of one another. Okay? I'll see you Wednesday. Thanks.
Thank you.